Hey guys, hey, Dr. Ash back with cellular concepts. We're going to talk about cancer, and more specifically today, we're going to talk about colon cancer and prostate cancer. So let's get started with an overview of cancer. So just as a reminder, it's in another video that I did with the cancer overview. Is just when cells lose their ability to control themselves. And so our cells inherently have a regulatory function of where they control how fast they need to reproduce, how fast they need to kind of regenerate and chew up old cells. And that just doesn't happen in cancer. Okay, so a cluster of these dysfunctional cells actually turn into a tumor. Okay, that's why they're irregularly shaped. That's why it grows. It's just because that cellular function is out of control. And so the alteration in function, the symptoms, how it spreads to other areas really depends on where it's at. And so I want you to think anatomically what is close to whatever we're talking about. So when we get to the colon and we talk about metastases, what's really close to the colon? When we talk about prostate, what anatomically is really close to the prostate that would make sense that the cancer could spread to? Because the cancer is only going to spread one of three ways. So it's either going to go into local areas. So what happens is pieces of the cells get shed or sloughed off, if you will, broken off into surrounding tissue. It can enter the bloodstream, or it can reach a lymph node or the lymph system, and in which case, once it hits the bloodstream or the lymph stream, it kind of can go everywhere and get out of control rather fast. So let's talk about colon cancer, also known as intestinal cancer. Is lesions in the cells that line the bowel wall. So it actually starts out inside the bowel, and a lot of people get diagnosed because they have polyps, and those polyps turn out to be cancerous. And so there are certain risk factors that place a person at higher risk for developing colon cancer. And so one of them happens to be over the age of 50, which is one of the reasons why screening is over the age of 50. A family history, if you have a diet full of fast foods or fried foods, fatty foods, things that the bowel does not really like. A history of those polyps again, people with inflammatory bowel disorders, which will be covered in another video, and then a history of other cancers because, well, once you have cancerous cells in your body, you are prone to other areas developing cancerous cells. So let's talk about the metastases and the complications. So what can happen, number one, is that we can have a direct invasion through the bowel wall. So it actually starts out in the lining, but it can go to the outside of the bowel, and then it's fair game to get into the abdominal cavity. It can also get to the blood and lymph systems, because if you think about it, again, very logically, we have tons of little capillaries and vessels that run throughout our abdominal area, which is one of the reasons why we use it for dialysis, but that's a whole nother video for a whole nother time. But lots and lots and lots of blood vessels and capillaries that run throughout the abdominal cavity. And then of course, our lymph system can be found just about everywhere. And so the abdominal cavity is no different. Complications, number one, bowel perforation. So of course, if the cancer goes through the bowel wall, we have a high potential for bowel perforation. Also, if the tumor gets large enough, it can rupture the bowel. And so these are kind of the symptoms that you would look for: hypotension, a rapid weak pulse, abdominal distension, and fever, because it can very easily turn into peritonitis. So once bowel material, if you know anything about the bowel, that's the waste products left over in the body, that gets into the bloodstream, and then it can cause a serious infection. Abscesses and fistulas. Fistulas are actually openings or holes between the bowel walls and the loops of the bowel. It can cause fever and abdominal pain. People can hemorrhage because, again, lots of vessels in that abdomen area. And then intestinal obstruction, which would just look at vomiting, pain, and constipation. Also changes in bowel sounds. So that should kind of be a hint that one of the things that you would look for, or one of the interventions that you would do, is actually listen to bowel sounds. So kind of the first sign that people start to report is blood in the stool, because obviously, if you have a bowel movement and it's full of blood, you're like, what the heck is this? And you go to the doctor. Some kind of further along symptoms would be vomiting, weight loss, loss of appetite, and of course, anemia, because we have that issue with potentially hemorrhage and bowel rupture and things of that nature. So treatment can be chemo, radiation, or they can go in and do some bowel surgery. So they can create a colostomy, an ileostomy, or a bowel resection. Just some things to remember: that with a colostomy, the stoma, or the hole to the outside of the body, should be pink. With an ileostomy, we expect it to be red. Okay, so that is normal. What is abnormal would be blue or purplish in color, because that denotes that there's not circulation. And if there's not circulation, there's tissue death, which is in the circulation and perfusion video that we talk about. Some of the foods to avoid, because the ileostomy, nothing has really digested yet. And so we really want to avoid foods that are high fiber or high cellulose, which would be corn, string beans, and wheat rice. So those are just some high examples of those high fiber, high cellulose foods. They do not get broken down, and they will typically come out of the ileostomy. The other thing about the ileostomy is that liquid stool is expected. And so initially the drainage is going to be yellow, and then it's going to turn into more of a stool liquid brown as we begin to advance their diet. And the thing with corn, string beans, and wheat rice, they don't get broken down until later in the bowel. And so if you feed that to an ileostomy patient, that's exactly what's going to come out of the ileostomy hole. And then our bowel resections, this is just where they take out portions of the bowel and surgically place them back together, because, well, they're just trying to get rid of that diseased bowel, if you will. And just remember, they will require stool softeners after surgery because the bowel shuts down. And so constipation is really a big issue. So remember, stool softeners after bowel resections. So teaching, a lot of people think they can just do a hemocult, or not hemocult, but a fecal occult. So finding blood in the stool, and they're like, okay, I got it, or I don't have it, and I'm good to go. But really, colonoscopy is the way to definitively diagnose colon cancer. So they have to have a colonoscopy. And then when we talk about dietary, we want them to decrease animal fats, decrease refined carbs, increase fiber, increase broccoli and cauliflower, because those are those bulk forming, very high fibrous kinds of vegetables to go in our diet. All right, let's move on to prostate cancer. This is a very slow growing tumor of the prostate gland. It usually originates in the androgen dependent cells. And so what I want you to remember from this primarily is that it's the hormones. Okay, so hormones are our number one enemy when it comes to cancer, because once our hormones get out of control or don't do what they're supposed to do, they directly impact cellular regulation. So that's why you see a direct correlation between hormones and cancer. For instance, here, testosterone and prostate. For females, it would be estrogen and breast cancer. So just kind of keep that in the back of your mind. Risk factors for prostate cancer: as we get older, things don't function the way they're supposed to. So again, that prostate loses its cellular regulation ability. Exposure to heavy metals like copper and iron. Of course, smoking is a direct link to almost every cancer. Frequent sexually transmitted infections. So men who have lots of issues with STIs, or frequent STIs, recurrent STIs, whatever term you want to use, they're at higher risk for developing prostate cancer. Just a little fun fact: anybody who suffers frequent infections have a higher risk of infection, have a higher risk of cancer. And then unfortunately, our African American males are at highest risk of all the ethnicities. So again, metastases and complications, I want you to think about what physically is very, very close to the prostate. So direct invasion of the tissues. Again, the blood and lymph system can be involved. Unfortunately, the prostate is right around that area of the pelvis. And so it can very much so have bone involvement, leg pain that radiates down both legs because it is metastasized to the bone. They can have spine pain. So really, when we have a prostate cancer patient that comes in and they complain of leg pain, the very first thing that should come to your mind is that it's potentially spread to the bone. Assessment findings, very sadly, this is asymptomatic very early on. So, very early on, a lot of times patients don't even know that they have prostate cancer, especially if they have not been screened. It may start as a hard pea-sized nodule, irregular shape, and enlarged prostate. And so I want you to think back to the BPH conversation that we had. If you haven't seen that video, there's a video on benign prostatic hyperplasia or hypertrophy, or they change the H all the time. But basically the enlarged prostate is going to put pressure on the urethra. And so dribbling of urine, nighttime urination, hesitancy, urgency, frequency, but they don't really pee a whole lot. So enlarged prostate. And then painless hematuria. And this is really what triggers males to go get checked out because they don't like blood coming out in their urine. So hematuria seems to be the first kind of, oh, let me go get this checked out kind of thing. Diagnosis can be done with a prostate surface antigen or a PSA, which can be normal to high or high normal, a high acid phosphatase, a digital rectal exam or DRE, and then of course the most definitive way to diagnose it is a biopsy of the prostate. So a couple of things that they can do for interventions once you're diagnosed, there's some non-surgical things they can do. Number one, they can put you on an androgen suppression therapy. And basically that's just blocking the testosterone from producing. But of course, if males don't have testosterone, it gives them kind of female characteristics. So typically males don't really enjoy the side effects of androgen suppression. There's also something called active surveillance. And so basically they just watch and wait. And this is going to be a direct rectal or digital rectal exam, DRE, and a prostate surface antigen or PSA. So this is where the patient frequently goes in and has their PSA level drawn, and they have a rectal exam to for the physician or provider to palpate if the prostate is getting any bigger or if the tumor is getting any bigger. Sometimes they can be put on luteinizing hormone, and then of course the obvious, which would be pain meds, radiation chemotherapy, steroids, bisphosphonates, which would actually help treat osteoporosis, mostly related to the bone involvement that is at high risk for our prostate cancers. And then surgical, we can have the transurethral resection of the prostate, which again is covered in another video. But after the TURP or the transurethral resection of the prostate, patients are often put on antispasmodics, and this is just so the bladder doesn't spasm. They usually have that continuous bladder irrigation. They are on patient-controlled analgesia for pain control, and then ice. Of course, we want to ice the area because it will get bruised and swollen, and men don't tend to like that. And plus ice helps with the pain as well. And so that is it. I hope you guys enjoyed that very quick and down and dirty, like I like to say, overview of cancer, and specifically prostate and colon cancer. So we'll see you in the next video. Don't forget to like, comment, or share if you found this helpful for any upcoming material.